I'm very happy to give over to Gert Molenbergs and his presentation about the statistical evaluation of surrogate endpoints. Please, Gert, go ahead.
Thank you very much for the kind introduction, Dieter, and for the opportunity to be here with you this afternoon in Europe, this morning in the United States and North America, the Americas, and this late evening for those people joining from the Far East, including China. It's a very great pleasure to be here in this group that is also very close to my heart, not in the least, because of the long-standing and very strong collaboration with Dieter and with the teams of Ideal and very many related projects. When I'm able to say a few words, so to speak, in the coming hour about surrogate markers, surrogate endpoint evaluation, then that's only because of a very strong and long-standing collaboration with a large number of people. Too many to mention, but let me be brave and mention a few. Of course, Mark Buijsen, present and also discussant, later on, with whom I've worked on the topic since April 1994, to be precise. Ariel Alonso, also present, and Wim van der Elst. And Ariel has also done a considerable amount of work, and several of the things that he contributed I will be able to touch upon. I'd also like to mention colleagues like Tomasz Brzykowski, Ziv Skedi, and again, many others, too many to mention all, including many PhD students, postdocs over the years, inside our institutes at Hasselt and Leuven, but also and at IDDI, because that's an important partner, but also in many other places. And I should also like to mention the strong and fruitful collaboration with the industry in this topic, including, not limited to, but including in particular, people from GSK, from J&J, etc. So without further ado, let me start the overview, and I'll try and build a house of surrogate endpoint evaluation, so to speak. And while I'm familiar with the area of rare diseases, so that also means small clinical trials, the overview is actually general and will roam over a variety of therapeutic areas. So we have a clinical trial, and we have the well established true endpoint, but that may suffer from a few problems. It may be rare. Think, for example, of a survival endpoint that, well, in many subjects would not be recorded for many reasons. For example, because many people, thanks to a successful therapy, don't make it to the endpoint. And if you do want to include more, you would have a long clinical trial. So a surrogate endpoint tries to mend at least one of those two problems, and hopefully both. For example, there are a number of other reasons, and the list is not exclusive. It's not all possibilities. The true endpoint may be invasive. It may be expensive from an ethical as well as from a financial point of view. And of course, as endpoints may lie into the future, a number of events may happen in the meantime. We tend to call those often intercurrent events these days, so that randomization is actually jeopardized. I can give many examples. You can also find those in our publications and in the books that we have done over the years with a number of people, Mark, Ariel, and I, Tomasz Brzykowski. There was a first and there was a second one. The second one is only 5 years old, but still the field has been moving on. For example, I'll give several examples, but I will not discuss them in detail, just to give you an overview. Myocardial infarction, if the endpoint is death, you may need thousands of patients over half a decade. Whereas if you look at things like ejection fraction, for example, you may be done in a month or a couple of months with a sample size that is 10 or 100 times smaller. Now, at this point, it should be clear that looking at another endpoint is not sufficient. We can always do that, but the question is, of course, going to be, do we get sufficient information from the surrogate about what we otherwise would have gotten from the true endpoint in one way or another? So is there a relationship? And I'm avoiding the word correlation at this point because we have to be a little bit careful with that. A few definitions. And I'm not saying that these definitions are the one and only way to look at it, but it's just useful for the coming hour or two to know what at least I'm talking about. The clinical endpoint, often also called the true endpoint, is the characteristic on which you would like to have an influence with your therapy. By the way, let me already say now, if we talk about a clinical trial, and so treatment in the clinical trial, we will often I will actually assume throughout that the randomization is over 2 groups. It doesn't need to be. It can be 3 or more, but for the sake of this presentation, let's say we have placebo active treatment, or we have standard treatment and experimental treatment. A biomarker, in the broadest possible sense, is a characteristic, objectively measured, that gives you an idea about healthy functioning or pathological functioning of the human system. And so a biomarker doesn't need to be a surrogate endpoint, but it can, of course, be a candidate surrogate endpoint. Is every surrogate a biomarker? No, because, for example, you can have gamma-type endpoints, scales, quality of life scales, for example, or more generally in mental health, you can have all sorts of instruments that are used as well that are not biomarkers, but still candidate surrogate endpoints. Few other examples, and you can look at them in peace and quiet also later. In ovarian cancer, the true endpoint may be or may have been survival, whereas we may want to look at CA-125, a very typical example. Let me go to the bottom of the slide. Prostate cancer, prostate-specific antigen may be a candidate surrogate. And by the way, I want to emphasize, it's not because I showed something on the slide here that I'm listing fully validated surrogates. No, it's places where you would start looking, for example. Prostate-specific antigen, by the way, may be very variable from one patient to the next and may as such not be a perfect marker, far from that. But if you start following it longitudinally, its promise may increase. So at one point in the presentation, I'll say a few words about longitudinal endpoints as well. Good, we can continue across a variety of areas. Let me take, for example, arrhythmias, where survival also may be the natural true endpoint, but arrhythmias itself, the occurrence, the measurement of arrhythmias, may be an obvious surrogate. HIV/AIDS is a world of its own, and there we can say from the early 90s until now, we really have changed endpoints a lot under pressure of evolution, developments, the successes that we had along the way, going from nothing at all to finally finally for the time being, the hard therapies, the cocktail therapies, so to speak. So early on, we looked at survival, then came CD4 counts, T4 cells, viral load below detectable limits, etc. And you will see that actually I changed the nature of the endpoint. When I say survival, it's the time to event endpoint. That's what it is. CD4 count is pretty continuous, so is viral load. But viral load below detectable limit, yes or no, that's pretty much a binary endpoint, etc. In ophthalmology, you can look at visual acuity, and we will actually do that. But you could also look at intraocular pressure for at least certain ophthalmological conditions. Good. We have to be a little bit careful when we look at one thing and we think this is sufficient to look at the true endpoint, and we don't really need to look at the true endpoint all that much. There are two famous, or I should rather say infamous examples on this slide. The CAST trials, and that's why I actually highlighted arrhythmias a moment ago. Cardiac arrhythmia suppression trial, the enconite and flecainide drugs did reduce arrhythmia, so quite successful, but unfortunately the death rate increased threefold, and that's not necessarily what you want. And it's quite interesting, if that's the right word. I don't know whether it's the right word, but interesting here means that, yeah, the actual therapeutic effects and the very much unwanted, this very serious fatal side effect is in the same therapeutic area. So a way to, not just for notation, but also a way to think about surrogates is you have your treatment, and hopefully the treatment ideally will have an effect on the true endpoint, but you place a surrogate in the, let me already use that term, causal pathway from treatment Z to true endpoint T that captures the entire flow of action. That's the ideal world. Perfection is not of this world, so there will be a but at one point. So, for example, you can say we have a change in diet as our treatment. We do or we don't change diet. The true endpoint is colorectal carcinomas, but colorectal polyps are like a very nice surrogate that captures all the effect. And the word all is a bit too much in my sentence, because you could, for example, also have apoptosis, which is a second route of action. So I think much more realistic is that the surrogate captures a certain amount of action, and therefore is useful in its own right, but not all. And then, of course, it becomes a matter of not quality only, but quantification of just how much of the effect is captured. As we go, we will try to formalize these concepts and build up step by step a framework, which I haven't really started yet at this point. Good. I promised to go back to age-related macular degeneration also, so ophthalmology. I mean, I did not promise yet to go back to age-related macular degeneration. I promised to go to ophthalmology, so here is the time. We have patients, typically patients that get a little older, and they progressively lose vision. Perhaps, but not necessarily, because of elevated intraocular ocular pressure. So this is an old study. We can say that now we go back to 1997, at which time we compare placebo with interferon alpha at 6 million units. What is perfectly possible is that your true endpoint is recorded at a certain point in time, and your surrogate is actually related to that, but at a different, typically earlier point in time. This is, by the way, a multi-center study. Patients are split over 36 centers. It's a small study with about 200 patients. And the plot shows very simply the horizontal axis is the change in visual acuity relative to baseline at half a year into the study, whereas the vertical axis represents the true endpoint, so to speak, after 1 year. It's change versus baseline, so that's why you have both positive and negative numbers, because visual acuity itself, if measured in this way, with a this is an unstandardized vision chart, but if ophthalmologists use a properly standardized vision chart, I hope everybody can read this well. And if you can't, it's time to go see your optometrician, for example, or your ophthalmologist. But we start from a vision chart with 70 letters. So visual acuity is 0, 70, or any integer between those. And then you can look at change versus baseline. For example, okay, other examples will pop up as we go, but let me go to, as Dieter already alluded to, the foundation of the house, which is Prentice's definition. I think it's fair to say that Prentice put this field on track in a seminal paper in Biometrics 1989, where he said with a very intuitive definition, whether you test for a treatment effect on the surrogate or on the true endpoint, it doesn't matter. It gives you the same information. That's very informally, verbally said what the definition means. Of course, if you think about it for a moment, and this is very relevant for this audience, in which many people are interested in rare diseases, you can have a small clinical trial. You will have no treatment effect on the true endpoint, no treatment effect on the surrogate endpoint, and you can say, hooray, they agree. Yeah, because you have lack of power, too small a sample size. That's not a proof, we know that, and that's also true in this area. Am I criticizing Prentice? I would not dare to do that, and Prentice, of course, knew that from the beginning, so he also put forward three 3+1, I should say, criteria. There are 3 criteria on this slide, but I'm keeping the best for last, criterion number 4. So we actually have a 3-body problem. We have the treatment, we have the surrogate, and we have the true endpoint. So the first 3 preamble, if you wish, criteria are, is there a significant relationship between the 3? Now, I've actually quantified that using statistical models, assuming that the outcomes are continuous, maybe even normally distributed, and we know that's very often not the case. Don't worry about that. All the methodology that's needed has been developed for about every endpoint you can dream up, but for simplicity, I would like to stay for a moment with simple linear models, that is. So if the alpha, the beta, and the gamma are all significant, the 3 criteria would be satisfied. Now, before you run away too early with a message, we have moved away from Prentice's criteria. Let me be clear about that. I'm just, for historic reference and to sketch the evolution and to give motivation to indicate where we are and why we are where we are in 2022, I'd like to go back to the beginning. So J is the indicator for a patient. We have a trial and we have patients, let's say 190 patients, like in the ARMD trial. J will run from 1 to 190. The funny thing sitting here on the side is because, of course, the surrogate and the true endpoint are measured on the same patients and may somehow be related. And I will come to that. We have to come to that, evidently. So here are the 3 criteria. They basically say that the treatment is related to the true endpoint, the treatment is related to the surrogate is related to the true endpoint. And then comes the infamous Prentice criteria number 4, often called the Prentice criteria, which basically goes back to what I indicated earlier. All the effect from the treatment to the true endpoint passes via the surrogate. In other words, if you correct for the surrogate in your equation, there is no treatment effect left. You've captured it all. There is no direct treatment effect anymore. That arrow wouldn't be there, or at least it would be sufficiently non-important to have a good surrogate. In classical epidemiological terms, we would say we have a treatment effect unadjusted for the surrogate, and we have a treatment effect adjusted for the surrogate. And you can use these 2 quantities to come up with the infamous PE or PTE, standing for proportion of treatment effect explained. Now, we are a few years down the line. This is work done by Friedman and his colleagues in 1992. So that was the next step. He actually brought what is looking like, is there an effect, yes or no? So hypothesis testing, he brought that to quantification, estimation of a quantity. Now, this quantity in 2022, or this concept, is not dead yet. It's still there, but I think it's fair to say that a number of people, including many of us, think the original quantification was actually a bit ill-posed. Is it a criticism? Not really, because the contribution of Friedman was to say, okay, we should quantify it, we should estimate the proportion explained in this case, but I'll allude to the problems with it and indicate several ways to move beyond the original problems. If I'm not mistaken, in 1998, a couple of people, and I think they included Mark Boyce and myself, proposed other quantities, including the relative effect and the adjusted association. The relative effect is a bit like a conversion from, let's say, I don't know, Deutschmark to euros, or Belgian francs to euros, or French francs to euros. It's a ratio that you can use to converge. Now, or there's actually a little bit of a difference between the conversion of Belgian francs to euros, because we all know that that ratio is 40.3399. Whether you translate 5,000 or 5 billion Belgian francs, it's the same ratio. That's a little different in a clinical trial, because you estimate there is uncertainty to begin with, but you estimate a treatment effect on the surrogate endpoint, treatment effect on the true endpoint, and who on earth, based on a single clinical trial, is able to say that this relationship, which is not just linear, it's actually multiplicative, that's a very strong assumption, is satisfied. So we'll have to revisit that in a moment. I think, just like the proportion explained, it's not a bad concept, but we need to move beyond it. The adjusted association goes to a different level. Look at it. The blue relative effect looks at the relationship between two treatment effects. And it's natural to say this is something that you would like to compare from trial to trial, from one trial to the next. The adjusted association says, okay, given treatment, is there a relationship between somebody's surrogate and true endpoint? Somebody's, the individual patient. So the adjusted association lives not at the level of the trial, it lives at the level of the individual patient. And from the beginning, you would have more than one patient in your trial. Unless you look at trials with only one patient, we don't. Even though we have small clinical trials, we want some replication there. So I'd say, with all the attempts that I've presented now in the first 15 minutes, the adjusted association is the one that's going to survive longest. Okay, here we can quantify it for the age-related macular degeneration trial. I could take a very simple approach and say the first criterion I look at non-significant, game over. Huh? So if we would use Prentice's framework, it would be game over. You see that the proportion explained does have a pretty large confidence interval. And if it would be a proportion, which it isn't, and that's one of the problems, it's defined as a proportion, it's called a proportion, but it actually isn't a proper proportion in its original definition. Moreover, it tends to have wide confidence intervals. And that's a problem, but the fact that it's not a proper proportion, I think, is a much bigger problem. The relative effect, we should say, okay, also there, we don't seem to get a lot of precision, because of course it's based on a single trial, whereas the adjusted association gives us meaningful information. If a correlation is 0.75, and you can say it ranges from 70 to 80, well, that's information that gives some, that has some meaning, because it's sufficiently precise. So I will not go into the technical and mathematical details, but the problem with the proportion explained is that it's actually writable. You can rewrite it as a function of the adjusted association and the relative effect. Now, one quantity lives at the level of the trial. The other quantity lives at the level of the patient. So that's already a bit of an amalgamation. I'm not entirely sure it will be easy to understand, but you can also show that it depends on another quantity, a variance ratio, which essentially has to do with measurement error, which is not so essential. So brief, the proportion explained in the way it was originally defined has its problems. I should say that nowadays, many papers are still written about the proportion explained. So am I saying with a sweeping statement that this is all wrong? Of course, I would not dare to say that. So I'm not going to say it, because often this is no longer defined in the original way. So there are a lot of quantities that people have put forward, including us, that capture the spirit of that basically still capture, I think capture is the right word, the amount of information that passes through the surrogate versus what remains unexplained by the surrogate. That's a very powerful concept. We will not throw that away. But what we will do is, and I think you heard me say that now a few times, bring the relative effect from an evaluation in a single trial to the multiple trial case, into a trial level measure of surrogacy. So if I run the next trial, will I be sufficiently confident that my surrogate endpoint, the treatment effect on the surrogate endpoint, is sufficiently predictive for the treatment effect on the true endpoint? And now I'm using a new word, prediction. Prediction is what is going to happen in a new trial. And that's essentially what you'd like to do. At the level of a single trial, you may want to predict what's going to happen for a patient at the individual level. That's also a very important clinical question. So relative effect and adjusted association will move one floor up. Okay, so what is the consequence of this? We need data. And I'll say it already now, but I'm sure that in the next hour, when we go into the discussion, I predict that the concept of data availability will come up several times, because you need data. Multi-center trials is a good start, but ideally meta-analysis where you have independent trials replicated within the same program, but maybe even cross companies. Several meta-analyses should be combined, etc., to go to this not only individual level, but also trial level measure of surrogacy. Early on, and now we're talking a quarter of a century ago, Albert and a number of colleagues in a very important Statistics in Medicine paper did refer to the need to go meta-analytic. They did not propose a solution yet. I'm happy to say that we are one of the groups who did. And they were also struggling still in those days with the interpretation of the proportion explained. But of course, also very important, something that clinically and biologically we should not lose sight of. We should try and understand as much as we can the mechanism of action, the biology and the pharmacology behind the drug that we are studying. Good. Let's do what I announced and let's go meta-analytic. So that means that our index J, which was indexing patients, like on S and on T, is now becoming a double index, IJ. So if I have 20 centers and every center has 100 patients, I runs from 1 to 20 and J runs from 1 to 100, for example. Other than that, it's the same pair of models, a model for the surrogate and a model for the true endpoint, that nevertheless are coupled. And of course, you would have a treatment effect in each of the 20 trials separately. And now we are in a position to study the relationship between these treatment effects. Do they agree closely with each other? Does one predict the other or not? That's the question we are faced with right now. So we can mathematize that, we can make that very mathematical, build a hierarchical model around it and do study that effect. But with your permission, especially for the clinicians among us, I will show some mathematical formulas. I will not dwell on them. There will be no exam on the mathematics at the end of the, as far as I'm informed, of the webinar, but rather look at the concepts. What does it do? So, for example, for the age-related macular degeneration trial, we have a plot here, not of the individual patients anymore, but we have a plot of the treatment effects on the true endpoint and on the surrogate endpoint in each of the centers separately. It's still a single trial, but it's multicentric, so you can use the centers as an unit of replication. Circles are a bit bigger for studies that are a bit bigger, and so the area of the circles is proportional to the size of the study. And if the relationship is tight, so the points lie close to the regression line, then the prediction, and that's what we do here, the prediction should be good and precise. Now, of course, you can capture the quality of a prediction, for example, by an R-square. And one of the advantages of an R-square is it generally lies between 0 and 1. And throughout statistics and the areas to which we apply statistics, like clinical sciences, we do have a feel for what it means in R-square. So the R-square trial here is 70%, so to speak. You can also do that at the individual level and say, okay, given now not a trial, but an individual patient, if I know from that patient the treatment allocation and the response to the surrogate, how well can I predict the response to the true endpoint? And recall that for the ARMD trial, the adjusted association was 0.75. The R-square at the individual level is 0.50. And that's actually reasonably close because the R-square, if you translate that into an R by calculating the square root, you get a number 0.70, which is fairly close to the adjusted association. So that's what I said earlier. Where we now are, we are in the meta-analytic context. We have treatment effects from trial to trial on both endpoints. We also have the individual responses, and we can quantify surrogacy at the individual level and at the trial level in both cases with an R-square measure, which is symmetric and nicely interpretable. Okay, that said, there is ARMD, and that's the first column in this overview where I have, if I go from top to bottom, Prentice's criteria, and then the intermediate measures, the proportion explained, relative effect, adjusted association, which was just a stop on the way on the road to the R-square at the trial level and R-square at the individual level. Let's not only do age-related macular degeneration, but also take a look, for example, at ovarian cancer and colorectal cancer. I will not give too many details about the studies in order to speed up a little bit. But what are the endpoints? Surrogate endpoint is progression-free survival or overall survival, whatever happens first, and the true endpoint is overall survival. The Prentice criteria would get us nowhere. But if you look at something like the proportion explained, you basically get to see it all. 1.34, case in point that the proportion explained is not a proportion because usually they're not above 1 and they're not below 0. But I do get fairly meaningful results if I look at the new measures, the R-square at the trial and at the individual level. They're actually both pretty high. They're a bit lower in the colorectal cancer case. But one thing that we should keep in mind is what is the gain in going from a true endpoint to a surrogate, for example? You might say, well, if the R-square trial is 0.94, why would you not go to the surrogate? Well, I would say, wait a minute, if the surrogate now happens very close to the true endpoint, you may not be gaining a lot of study time. So perhaps even if the gain in study time is bigger, perhaps then I can live with an R-square trial that's a little bit lower. So there is this trade-off, and you can quantify that, but only to a certain extent that there is actually clinical judgment at one point. You should basically weigh against each other the time gain, the gain in comfort, the gain in cost on the one hand, and the quality of the surrogate on the other hand. Just a little bit more of the same. This whole slide is devoted to mental health, to psychiatry. We have studies in schizophrenia, 2 studies. So there is study 1, but you can look at that study as consisting of 138 investigators or 29 primary investigators, and then study 2, which for our purposes, we can see a replication. We can see as a replication. If we hadn't seen it all, we now have seen all because we even have a negative proportion explained. And if the original quantity was not that yet, I think it is now at this point, of course. But also here we see that, of course, with some goodwill, if we look at the R-squares at the trial level and at the individual level, there is a common message emanating, 0.60, 0.65 at the trial level across the 3 ways of analyzing it, and 0.50 at the individual level. Good. I promised, and I will do that now, that I would not just stick with continuous endpoints. There is also something like binary endpoints, time to event endpoints, etc. With your permission, I will not go into too much detail, but just give a hint every time on how we proceeded, and then eventually how that led to another development. One way to think of binary endpoints is as dichotomizations, discretizations of continuous underlying endpoints. So if S is binary, you can say there is an underlying latent variable, S tilde, which if it's positive, you generate a 1, and if it's negative, you generate a 0. Sometimes that S tilde may be explicit, like in the age-related macular degeneration trial, where we have a quasi-continuous endpoint. One possible endpoint is the number of lines of vision that a patient has gained or lost, with a cutoff of 2 or 3 lines, for example, when that dichotomization is explicit, but even if it's implicit, you can also proceed in this way. Why is this a problem, and why don't we simply use logistic regression? Well, the model for the surrogate endpoint and the model for the true endpoint are coupled. I said that before. The surrogate and the true endpoint are measured on the same patient, so they are associated, correlated. Now, whereas correlation is a very natural concept for continuous Gaussian data, it's a bit less so for binary data, it's a bit less so for survival data. So we need to think of models to bind together these two logistic regressions, if you wish. And a number of techniques have been proposed, but this is starting to introduce some statistical complexity for sure. That's what I wanted to say about the binary case for now. For survival, because it's such a prominent case, we can have, well, you may have noticed, and maybe you were frustrated a little bit by the fact that I was analyzing in the colorectal and the ovarian cancer case, the outcome, which is time to event, as if it was a continuous Gaussian outcome, so that I could use linear models. That's, of course, not what most people would do. Most people would use survival models, a Cox model, for example. But again, I have a Cox model, say, for the surrogate endpoint. I have a Cox model for the true endpoint, and they need to be bound together. All I want to say is there is statistical machinery, copulas, for example, to actually do that. But you start to feel that, yeah, I need a variety of models, and it seems to depend on the nature, the statistical nature of the surrogate and the true endpoint. And that's true. And at one point, we would like to simplify that back a little bit, so that it becomes not just easier for the statistician, that's not the main problem, but that the interpretation is sufficiently intuitive also for clinical practice. So as I said, we have the Clayton copula, we have the Hugard copula, they all have their properties, etc. Let's leave it at that. But once you have a model that binds the surrogate and the true endpoint together, I can apply that. So we will now say, statistician, please do this for me for every trial separately, so that at the end of the first step, I have a treatment effect on the surrogate and a treatment effect on the true endpoint, just as we had before. And that allows me to study the association, just as we did before, and come up with an R-square. So where does that leave us? In the continuous case, I had an R-square at the trial level and an R-square at the individual level. When I go to binary endpoints or time to event endpoints, for now, we have to let that loose. We have to let that go, at least at the individual level. But fortunately, at the trial level, we still have an R-square measure. And in many cases, that is the most important thing for us to look at, for example. So here you see these guys for the ovarian cancer case and for the colorectal cancer case, ovarian left, colorectal right, with the two copulas. And again, I gave very little detail about it. I will not change that. I will give very little detail about these copulas, but it's just good to know that if there are several model options available, that we can try a few of those. And if they would now radically differ from each other, then we should start investigating what is happening. But since here we get a pretty coherent picture, both for ovarian and for colorectal, and actually coherent with what we saw before when we were misanalyzing the data with Gaussian models. Well, we actually got a very similar picture. So that if we consider this a sensitivity analysis, we are quite comfortable with the result that we get. At the individual level, we don't have an R-square, as I said. We don't have a correlation, but we have something called Kendall-Stau. And fortunately, Kendall-Stau has an interpretation pretty similar to a correlation. So also that picture is coherent with what we saw before. For the mathematicians among us, for the die-hard mathematicians among us, it's not a correlation. But if you want to get a feel for what do I do with this guy, it's pretty much interpretable as a correlation. Okay, now I already alluded to the occurrence of longitudinal endpoints. Think about PSA, prostate-specific antigen. It may well make sense to measure prostate-specific antigen over time and use the evolution of a patient's trajectory as a surrogate, not just a single measure. But that means that now I don't have only trial, I, and patient within trial, J. I also have measurement occasion, lowercase t. So brief, my models get bigger. I have 3 levels in my hierarchy. So trial, patient within trial, and then repeated measures within those patients. Now, the example I gave a second ago was prostate-specific antigen as a surrogate for time to event. That's not what I'm doing in this slide. Here I have, for now, a true endpoint which is longitudinal and a surrogate which is longitudinal. To fix ideas, think, for example, of clinicians' global impression in the schizophrenia example, and then the brief psychiatric rating scale or the PAN scale, for example, both of which can, or all 3 of which, if you wish, can be measured longitudinally. Okay. Now, this is one of the many things where Ariel and colleagues have, Ariel Alonso, have contributed to. That is, yeah, I now have a way to think about it is, I have a surrogate and I have a true endpoint over and over again. As time goes by, I'm measuring my surrogate and my true endpoint. So I have a whole vector of surrogates. And I have a whole vector of true endpoints. Now I have to make sense of all of that information. And let me suffice by saying that one can use multivariate methods to summarize the information in all of those guys. The goal is, the ultimate goal at the end of the day, to get something that I can write for good measure as an R-squared type of quantity. So we try to push it towards R-squares. Not because necessarily we are married with the concept of an R-square or we have stock and shares in R-squares, but because it's easier for interpretation if at least the measures look sufficiently similar. Of course, the more information you have, the richer information you get. Yeah, the more you lose if you summarize things with just a single measure. That's, of course, a price you have to pay. Of course, you can have longitudinal data like prostate-specific antigen, but you can also have binary longitudinal data. You can measure counts, for example, epileptic seizures. That's a count. That's yet another type of endpoint. And what Ariel has developed at one point is the likelihood reduction factor, which is still the same concept, but now applicable to all data types. To, let's say, let's be careful, to almost all data types. And in the making also simplify the model exercise a little bit by saying, okay, I build a model for the treatment effect as a function of the treatment, and another model for the treatment as a function of the treatment effect, but also as a function of the surrogate. So in other words, the betas here on this slide, the betas, are the treatment effects without adjustment for the surrogate. The thetas are the treatment effects with adjustment for the treatment effect. And this starts to sound awfully much like the ingredients for the proportion explained. And yes, it is. But now, in a way, the likelihood reduction factor is a replacement for the proportion explained, but one that nicely puts you between 0 and 1. To take it one step further, and I'll be brief about it because otherwise this would get a little technical. That's also something that Ariel has contributed. An information theory approach has been put forward. And with many goals in mind, but one of the very important goals is to, at the end of the day, by using somewhat more complicated technical methodology inside of the bowels of the machinery, to make sure that computations remain feasible and that interpretation at the end of the day is as simple as it can get. So the output of the machine will be simpler, but the price you have to pay is somewhat more complex methodology. So entropy is actually a measure of variability. Don't we have a variance for that? Yes, we do, but the variance is a very clean and natural concept again for Gaussian data. But let me suffice by saying by using entropy, we're in a better position to unify various data types. I'm doing a bit injustice to the framework, but for us now, that is all we need to know. So you can say, what is the variability of the true endpoint as such? And what is the variability in the true endpoint if I first condition on the surrogate endpoint? It's always the same. It always has that connotation of proportion explained in it. And yes, by the end of the day, you can come up with a measure that is written as R squared. Now, it's not because we write R squared that it is nicely between 0 and 1. You have to prove that. And that has been mathematically shown without too much trouble. So a way to summarize where we are now is we started with the R squares. Well, we didn't start there, but we got there when the meta-analytic framework was introduced. Then we went to different data types, and oh boy, in different data types, we were dealing at the individual level with not so natural quantities for surrogacy. So we wanted to amend that and come up at the end of the day with measures that were as R square-ish as possible because they're easier to interpret. And that could handle Gaussian data. So continuous data like blood pressure, for example, binary data. Do you lose lines of vision, yes or no? Time to event data, progression-free survival, categorical data like tumor growth, and all of these things, or many of those things, also longitudinally measured. So a whole sequence of measures has been developed, and at the end of the day, guess what? We end up with measures that still are nicely R squares. And that as measure after measure follows, have nicer and nicer properties at the end of the day. One very important thing is that, one very important thing that I would like to emphasize here is, when we study for potential surrogate endpoint, we often take the true endpoint as a given. That seems natural. This is what everybody agrees upon. But what the information theory drives us to is also think a little bit about the true endpoint in itself. How variable is the true endpoint to begin with? And is it even possible to come up with a good surrogate? Not because all the surrogates are poor, but because the true endpoint is too wild. I'll give you an example from CD4 in HIV or many other respiratory infection. If my CD4 count is low, but somebody coughs in my face, we shouldn't do that. We never should have done that, and not even now after the pandemic. But just imagine, and my immunity reacts well, it will immediately shoot up. So you measure before and after that event, and you get a different reading, which basically tells us that there are a lot of, let's say, spurious evolutions in that CD4 count that would make it difficult to use that as an endpoint in a clinical trial. So the intrinsic, let's say, randomness, variability, let me call it wildness in the true endpoint, yeah, you're not going to tame by a surrogate. A surrogate cannot do better than the true endpoint. And this formula at the bottom, if I say that in words, is I criticize the proportion explained at the beginning, but the quantities that we are considering, the R squares, still carry that same concept. How much of the information in the treatment effect on the true endpoint is explainable by the surrogate? And the more, the better, of course, because it still means that causal flow goes in the right direction. All right, I was getting ahead a little bit a moment ago, but Famous inequality is a way to quantify what I said a moment ago, the quality of the prediction. So by prediction, I mean we use the surrogate to predict the true endpoint. The quality of that prediction is bounded by two things. First of all, the relationship between the surrogate and the true endpoint, so the R square, of course, but also what we call the power entropy, but I'm now going to use for the purpose of this webinar, the wildness of the true endpoint. Some true endpoints are simply not worth to be considered, to put it very blunt, but hopefully then the message is clear. Okay, I mentioned the schizophrenia trials before, so let's use some of the quantities that we had before. We have continuous outcomes in the schizophrenia trials, but so for example, the BPRS, a brief psychiatric rating scale, the positive and negative syndromes scale, the PAN scale. We can analyze that as continuous outcomes. And then we see that, the individual level surrogacy is pretty low. The trial level surrogacy is a bit more promising. Or we can look at the binary outcomes, where at the trial level we still have our squares. So let me remind you that at the trial level it's easier to get R squares, because you get a treatment effect at the true endpoint, you get a treatment effect at the surrogate or for the surrogate, and you can study the relationship between these treatment effects. That can be done quite easily with R square measures. But at the individual level, we had to go through all of the hoops with information theory at the very end, and with the likelihood reduction factor, etc., to, at the end of the day, have that information measure. Now, here I have to say, for binary data, that information measure is nicely confined to 0, 1. But there is another problem, though. Depending on the application, it may not be possible to reach the ceiling, i.e. 1. So, of course, it's better that it still lies between 0 and 1, and you cannot reach 1, then that you suddenly get -4 or 1.23. That's not what you want. But if 0.27 is in a range that has an upper bound, let's say, of 0.28 or an upper bound of 0.95, that makes a big difference. So it's actually possible to rescale it such that you basically divide away the maximum and the quantity gets back to the 0-1 intervals. So you see that unfortunately there are some technicalities we have to deal with, but the bottom line is, if you believe the machinery, at the end of the day, you have, regardless of the data type, you have an R square measure at the trial level, you have an R square measure at the individual level, which is interpretable. It's basically one and only one concept that we push forward throughout, but you see that there is a whole machinery behind. Same for the age-related macular degeneration trial, when both outcomes are binary. We can look at the R-square trial. We can look at the information theory-based measure, which is this, this R-square H here. We we keep retaining our R-squares. By the way, very often when you dichotomize the outcomes, the result, the surrogacy, is not as good as you have a continuous outcome. It's not always the case, but often that is the case, because of course you throw away a lot of information if you dichotomize. It's not different from other areas where we do dichotomize. Advanced colorectal cancer, where we would typically use a Cox model because we have time to progression or death, whichever occurs first as a surrogate. We have time to death as such for the true endpoints. So if we would study one endpoint and only one endpoint, people would use a Cox model, proportional hazards model, if you want to call it that way, and that would be it. So again, what do we do here? We fit a Cox model for the true endpoint, period. And we fit a Cox model for the true endpoint, but also correcting for the surrogate. And then we compare the two models, and if a lot of the effect is taken up by the surrogate, we have a good surrogate, and we can look at, we will be looking at a high R-square at the trial level. So here you see for two colorectal data sets that no matter how you look at it, with the good old-fashioned copulas, or with independent models or whatever, you get a decent R-square. If you look at the individual level, you see that you also get a fairly strong relationship, because this is also now interpretable as an R-square. I want to repeat once more that in all of those cases we get R-square measures. One thing, and that's work that Mark Boyce and Thomas Berzikowski have done to a large extent, is one thing that you may also do is say, okay, I now have this quantification in R-squares, etc., but how well will I be able to predict the treatment effect in a new trial? So let's say I have 20 trials, 1, 2, 3, 4, up until 20. I have evaluated my surrogate. It's a good surrogate. We're going to apply it to a new trial, number 0. Okay, in that new trial, I will only look at the surrogate, and I would like to predict the treatment effect on the true endpoint without measuring it. Well, of course, because you predict from something else, that's not going to improve the precision. It will deteriorate a little bit. You just hope that your surrogate is good enough so that the deterioration of the precision is still acceptable, and you are still able to find a reasonably precise treatment effect. But to cut a long story short, so you can look at the prediction variance and you can make a prediction. It's always very dangerous to make predictions without prediction variances. You have to know how precise is my prediction, and that depends on 3 things. You can write it down in formulas, you can also say it in words. It depends on the quality and the size of the evaluation exercise. It's clear that if you can run 100 trials with 10,000 patients each, and I'm exaggerating, you will be more precise than if you have 3 trials with 20 patients each. That's obvious. But of course, it also depends on the size of your new trial, because if your new trial is large or small, that makes a big difference. And then finally, it depends on the relationship between the surrogate and the true endpoint. If you have a huge validation exercise, check, that's good news. If you have a huge new trial, check. But if the surrogate and the true endpoint have nothing to do with each other, you're still nowhere. So these 3 conditions need to be satisfied. So the prediction in the new trial depends on the variability, the estimation error, the standard errors, if you wish, in the meta-analysis, in the new trial, and then the relationship between the 2. Okay, and so what Mark and Thomas defined based on that was the so-called surrogate threshold effect. That is the smallest treatment effect that you should realize on a surrogate so that it would translate in a significant treatment effect on the true endpoint. To say that differently, it's not because you have a significant effect of your treatment on the surrogate, that this automatically means, oh, it would have been significant on the true endpoint. No, that's not true, because this translation exercise brings in other sources of variability. And of course, that's not a universal thing. It depends on the number of trials in your meta-analysis. It depends on the size of the trials in your meta-analysis. And of course, it's going to depend also on the size of your new trial and the actual treatment effect. Okay, to round off in the last few minutes, I would like to make a few comments, but not more than that, about other frameworks. And one framework I haven't touched upon, but I have to, because otherwise Ariel will be not so very pleased, and Wim neither, because we worked on that all together, is causal inference. A way to think about what we have done right now is we worked with the observed outcomes period, and we did pretty much an associative studies. We looked at association, and that's what often the meta-analytic framework is qualified at. Causal inference would look at potential outcomes. That is, and let me start in 2 steps, and then, well, let me present 2 steps. Let me start by step 1, just on the true endpoint. Every patient has 2 true endpoints, one under placebo or control treatment, one under experimental treatment. Of course, unless you're in a crossover trial or in specific trials like allergies where you do tests on the 2 arms, you have only one of those. It's at best. If there are no missing data, there is the treatment effect under control conditions, there is the treatment effect under experimental conditions. So the individual causal effect is basically the difference between the 2. Again, working with continuous outcomes, and the expectation over the trial and therefore over the population is the expectation of all of those guys. And what you like to do in this first step is say, can I get a surrogate for that delta, or in actual practice for that beta, but at the individual level also for that delta. Now you may ask yourself, hey, why is he using 2 endpoints for the true endpoint and only 1 for the surrogate? Good point. We will rectify that in a moment. But there is actually one problem. So I promised to work with 4 endpoints in a moment, where I have also S0J and S1J, but not for now yet. But I would like to make a point based on this. We don't observe T0 and T1 together. Some patients provide T0, some patients provide T1. But that's a bit of a problem, because if there is a correlation between T0 and T1, I will not have the instruments to estimate that correlation, because if I can estimate the mean of T0 and the mean of T1, because some patients would provide one, some patients would provide the other, but never jointly. So while I can go through the motions now, the problem is a little bit that a crucial piece of information I am missing. So as I said a moment ago, the correlation between the true endpoint under placebo and under active conditions, that correlation is not identifiable. So what do you do when something is not identifiable? You start a discussion, and the one who shouts loudest, that value we take. Well, that's not a very scientific approach. You can make assumptions and reason these, make such a reasoning that in the end you believe that your assumptions are right. It's still flying a little bit blindly. So the approach that we as a team usually take is, let's do a sensitivity analysis. Let's consider a plausible range of those correlations. And the clinicians around the table might say, yeah, and we might even give you some input. Good, we will take that input and filter that into our sensitivity analysis. And what you would get then is not a solution, but you would get a set of solutions. Now, that's also something that we're used to just by standard errors. If we have standard errors, what we basically say is we don't have a treatment effect. We have an entire interval of treatment effects. But if it excludes 0 convincingly, fine, that's all we need to know. It's in a way not different from that concept. Now, for those people who don't know what to do for the rest of the day, I have some technical slides on Rubin's causal model, where, and that's where I promised I would still go to, and then I'll stop. You have not just two endpoints for the true endpoint, two realizations for the true endpoint, one of which is observed, and the same is also true for the surrogates. The fundamental problem of causal inference is you can think of 4 things, you can only observe 2 of those things at most. That's the fundamental problem. And it's not different from what I said a moment ago. Now you have it for the 2 endpoints. We have to do some, again, mathematization to get this all properly under control. And people like Ariel, Wim, many others in the team have been doing that. And not just us, also other teams are working with causal inference frameworks with a lot of variations to the theme. But essentially, what you have is a 4-dimensional vector. Let me rephrase that. You have 4 outcomes in your mind, but only 2 of those in your Excel sheet. And so that now means that more parameters are not identified. And that's why I, for a moment ago, passed via a single surrogate, 2 true endpoints, because then I could put my finger on one parameter that was not identifiable. Take it from me that now we have more. And if you would dare to make this longitudinal, you would really have a lot of parameters that are not identified. Can you work your way around it? Yeah, but with some painstaking computations. There is no free lunch. So we want to work with those differences, and we want to translate those differences into, guess what? You can almost predict what I'm going to say, R-squared type measures, but based on quantities that of which some I have, for which some I have the information to identify them, for some others that would not be the case. So indeed, you can come up with R-squared type measures or correlation measures. But if you square a correlation, it's also an R-square. And don't be afraid of the formula. It doesn't bite. It can be calculated. It's available in packages also. But the essence is, at the end of the day, even in the causal inference framework, I can come up with R-square measures, but do know that there are unverifiable assumptions. And these will filter into the uncertainty. Now, the nature of the invariable, you can say, okay, there is a certain correlation that I don't have. But if we have a discussion between statisticians and clinicians, we might come to the conclusion that the negative correlation is very implausible. If that's the case, we can already exclude that and simplify our life a little bit. Let's assume that we develop a vaccine. We might actually start from the premise that in the worst case, the vaccine would be like saline, it doesn't do anything. But it's not going to make you more vulnerable for the infection. It's going to make you equally vulnerable or less vulnerable to be infected or to get a serious infection, etc. Some of you who know the vaccine area very well may say, wrong. There are examples where actually the vaccine was unfortunately priming not the patients, the study subjects. So there it would have gone in a different direction. But if we're clinically reasonably sure about a certain assumption, we can limit our uncertainty a little bit. So statisticians and clinicians together can work around non-identifiability, can work with non-identifiability, and still come up with a meaningful conclusion. So what I wanted to say about that is, where do statisticians get information from? From the data, that's clear. But don't forget also the design. Randomization is a very powerful paradigm. I think with Dieter around the table, I had to say that, and many other colleagues would also, and that's true. If we design our study properly, they give information in and out of the design also, and the rest is assumptions. And around those assumptions, we can do sensitivity analysis. And then I wanted to end with this picture. You can then get a picture like this, where you say, if you're a person that it's the glass is half full or half empty, we can say, yeah, but look at this. the correlation, the R squared, the relationship between the true and the surrogate endpoint goes from 0 to 1. Every value is possible, but I think most people who would interpret this graph say there's a pretty high chance that the correlation, that the relationship, in other words, between surrogate and true endpoint is considerable. So this gives me a good feeling. That's if you're, let's say, a more positively intended person. And on that note, and my apologies for going slightly over time, I would like to stop and turn the word back over to the chair.